The LD at School team is very pleased to welcome our guest speaker, Dr. Marjorie Phillips, whose presentation this afternoon is entitled Recognizing and Supporting Anxiety in Students with LDs. The Ministry of Education provided funding for the production of this webinar. Please note that the views expressed in this webinar are the views of the presenter and do not necessarily reflect those of the Ministry of Education or the Learning Disabilities Association of Ontario. We will also be tweeting throughout the webinar, so if you would like to participate, you can send us a tweet. Our Twitter handle is @LDAtSchool, which is displayed at the bottom of this slide. And that takes care of housekeeping for this afternoon, so let's get started. It is now my pleasure to introduce our speaker, Dr. Phillips, who is the director of the Integra program at the Child Development Institute. The Integra program at the Child Development Institute is the only accredited children's mental health agency in Canada to specialize in providing mental health services to children, youth, and families with learning disabilities. Dr. Phillips received her doctoral degree in clinical psychology from the University of Waterloo. Cross-appointed as an adjunct assistant professor at Queen's University, Dr. Phillips worked as a clinical psychologist and clinical director in a children's treatment rehabilitation in Kingston for 12 years. She joined the Queen's University Psychology Department on a full-time basis in 2004 to establish a psychology training clinic for graduate students and to pursue research interests in pediatric acquired brain injury and neurodevelopmental disorders. Dr. Phillips moved to Toronto in 2008 to join Integra, where she also held cross appointments as an adjunct assistant professor at York University and as a clinical supervisor with the University of Toronto. Welcome, Dr. Phillips. The cyber floor is now yours.
Thank you, Cindy. So welcome to everyone, and thank you for attending this webinar. It's Children's Mental Health Week, so this is entirely fitting that we're talking about supporting students with anxiety and learning disabilities. My hope for today is to address three things. First, to understand the nature of anxiety in students with learning disabilities, what it is and what it looks like. Second, to have a better understanding of red flag concerns, to know when to be concerned, when to refer on for professional diagnosis, and when additional mental health supports are needed. And last, we'll review some practical strategies to support these students at school. I wanted to start by putting a face on the kinds of students we are talking about today. Meet Tina. Tina is a 10-year-old girl in grade 5 who is a quiet and compliant student. She flies under the radar in class. Tina follows instructions, seems to work hard. Tina's been diagnosed with learning disabilities that affect her reading and writing primarily. Her teacher notices that Tina is frequently absent from class with illness. And when she is in class, Tina sometimes reports feeling sick. Her teacher thinks she may be a worrier, but Tina doesn't talk very much, and it's hard for the teacher to tell what is going on. In contrast, we also have Trevor. Trevor is a secondary school student in grade 10. He seems very bright, articulate. He loves to argue his points in class. And Trevor's high school teachers find him challenging because he questions everything, points out, especially whenever he perceives something to be unfair. Trevor doesn't seem to have friends or a social group. And attendance is also a problem for Trevor. He was diagnosed with LDs in grade 3, and his LDs affect his abilities in writing and in math, most notably. So what do Tina and Trevor have in common? Well, they both have been identified with learning exceptionalities, but they also both have anxiety, significant anxiety. And Tina may present with a conventional picture. that you may recognize, but today we'll also talk about how Trevor's presentation may reflect anxiety. So we'll start by ensuring we're on the same page in our understanding of learning disabilities. Consistent with the Learning Disability Association of Ontario definition of LDs and with the Policy and Program Memorandum 8 identification guideline in the school system, learning disabilities are neurodevelopmental disorders that affect one or more ways that a person takes in, understands, remembers, and expresses information. By definition, people with LDs are smart and can learn, have average to above average intelligence. There are specific areas of processing impairments that get in the way of learning. We understand learning disabilities to be lifelong. You don't grow out of LDs. However, they do look different at different stages of development or in response to different task demands. Also, LDs are the most common form of learning exceptionality in Ontario. 43% of students who have been identified have LDs. And when we talk about the impairments in information processing, we refer to specific difficulties in one or more of these areas: language, phonological processing, sort of manipulating the small sounds and words, visual spatial processing, processing speed, memory and attention, executive functioning. And the key thing here is that the combination of processing problems may be different for everyone. For example, you can have slower processing speed and difficulties in working memory, but good phonological processing or other combinations. What do LDs affect? Well, by definition, LDs reflect a functional impairment in some area of academic achievement, such as reading, writing, or math. However, they also reflect how one processes information more generally, which has a broader impact on life. 75% of individuals with LDs have difficulty with social interactions, and that can reflect different challenges depending on the natures of the LD, such as reading nonverbal social cues, social problem solving, tracking group conversations, and so forth. LDs can have an impact on behavior. We'll talk about that today. And for some individuals with LDs, there can be difficulty with emotion regulation or managing intense emotions, overregulation, freezing up, or underregulation, meltdowns, and explosions. A common feature for LDs and mental health issues is that they are invisible. Often we have to infer from a student's behavior what may be going on. And students, particularly children and youth, may not be able to explain to us what's going on, and it may reflect not having the words or the insight, self-awareness, or the confidence to explain to others. We need, as the caring adults and educators working with these students, to be curious about what else might be going on when you see challenging behaviors. And a way to think of the student behavior is to think of it as the tip of an iceberg. For example, we may see behaviors such as non-compliance or being off task, inattentive, easily distracted. But these surface behaviors can reflect a number of things. Could be anxiety with worries that are really distracting and make it hard for the student to concentrate and listen to the teacher. Can be also ADHD, which we know has symptoms around inattention or distractibility, depending. Depression is associated sometimes with difficulties with initiation, getting started, or in concentration. We also know that depending on the nature of the LD itself, if you have a student with slow processing speed or executive functioning difficulties, that can look like off-task behavior. And then there can be some physiological things, like perhaps the student isn't sleeping well, and that would interfere with concentration. So the key thing here is to look below the surface and to consider what else might be going on. And the role of the educator, your eyes and ears are invaluable as the first line. You see the student sometimes day after day. It's an important lens to notice, to wonder, are they learning? And if they're not learning, what's getting in the way? So at the Integra program at Child Development Institute, We find this framework of Ross Green's just as a helpful framework. And Green writes that our understanding of the problem determines the solution. That kids do well if they can, and if they can't do well, then something is getting in the way. That there are lagging skills, and we need to help figure out what may be going on. So essentially, what may look like a stubborn refusal to do something may have originated with difficulties in doing something. It is hard to do things that are hard. And we need to find out in a behavior how much is a lack of skill, they're really struggling, they don't know how to do something, or how much is a lack of will, they won't do it. And the point of this framework is just to provide a way of thinking. It helps to minimize power struggles with a student. So it's not an either or, it's really trying to figure out and understand why. Why are they acting like this? So now let's look at the relationship between LDs and mental health. One way to think about this is to consider mental health on a continuum, from a green all the way up to the red zone. Many of us fall in the green zone of good mental health, meaning we feel generally pretty good. We may have social supports, we may be engaged. Generally, we have sufficient personal resources to cope with everyday life things. Doesn't mean we're always feeling happy, but generally life is fine and we're managing. Many of us, most of us, occasionally experience periods where we might move into the yellow zone of feeling stressed. And it could be changes, a new job, a loss, a family member who's struggling, changing schools, stress at work, worrying about someone. We may feel in these times a bit stretched and maybe tense. Maybe there's difficulty sleeping. Maybe we feel overwhelmed. Functionally, it may feel like the demands are exceeding our resources. And so for many of us, over time, that situation changes. I mean, we develop new coping strategies, there's some change in the environment, it's just time, things change, and we're able to go back into the green zone. And often that's one way of simplifying life, moving in and out of the green and yellow zone. But for some of us, the mental health issues can be more serious and have a functional impairment. For example, we may have significant low mood, and it may be really hard to get out of bed in the morning, or to get to work, or to get to school. That would be more of a red zone. Again, it's a continuum and then if we're in the red zone with interventions, sometimes with supports, with medication, we may move out of the red zone back to the yellow or the green zone. But often red zone needs something more. And at Integra, we see many of the students with learning disabilities as frequently falling in the yellow zone, with school as an ongoing stressor. Not all, but the students with LDs often experience more stress. It's hard to show what you know. School is a social environment. We've talked about the things that make that difficult. And for a portion of these students with learning disabilities, maybe as high as 40%, they move into the red zone with more serious mental health issues, such as anxiety disorders, as well as learning disabilities. At Integra, we've been calling this subset of individuals whose mental health issues are complicated by LDs, learning disability and mental health issues, LDMH. What do we know from the research about the relationship between learning disabilities and anxiety specifically? Well, we know that students with LDs have higher rates of anxiety. And in some students, 30% of children with LDs met criteria for an anxiety disorder. Most often this type includes a generalized anxiety disorder, but sometimes specific phobias and social anxiety is also common. We know from the research there doesn't seem to be a gender difference for this subset. Both boys and girls with learning disabilities have anxiety at similar rates, although the presenting issues may look different. And The research suggests that there is an association between learning disabilities and anxiety, but we don't really know the cause. One interesting area of new research coming from Neurobiological Studies suggests possible primary factors and suggests the possibility of a common underlying neural pathway for this LDMH group. Specifically, there may be difficulties in the pathway from the prefrontal cortex to the amygdala that are common to both LDs and serious mental health, such as having executive functioning difficulties and difficulties with emotion regulation. But we need more research to understand what's going on in the brain, and at this point, that's just an interesting theory. What we do know more about is that there are secondary effects of learning disabilities on mental health. Students with LDs experience considerable stress. First, typically there's a history of repeated failure experiences. Depending again on the nature of the LD, it could start with poor spelling tests in the primary grades or being rejected from social groups. Second, often students experience a lower sense of mastery. If you can't show what you know, you may feel stupid or incompetent in areas that seem easier for others. We also know that students with LDs often feel anxious about not meeting expectations. They may feel that they let their parents down or their teachers down. Most importantly, the behavior here may not always look like anxiety. To cope, the student may devalue the stressor, sort of say that math test sucks, or I don't care, and act as if they don't care. But again, it's hard to do things that are hard. And we see considerable frustration. All of that can lead to feeling bad, feeling anxious, worried, sad, hopeless. Usually no one likes to feel bad. And often that can lead to patterns of experiential avoidance, doing things to avoid thinking about worries, including not always wanting to engage in talk therapy. Often parents want their children to go to therapy and the kids don't really see the point of talking to someone about their feelings. Or avoiding the stressors such as skipping school or using substances as an adolescent. And often kids may perceive it's better to be dumb than bad. So let's look more specifically at anxiety. By definition, anxiety reflects distress or uneasiness of mind. It is part of normal development. We're exposed to new situations and we learn how to master our fears, such as sleeping with the light off as a child or starting a new school, a new job. Anxiety cues us to be alert, works as an early warning mechanism. It's normal to be a bit anxious about giving a webinar such as this one, or a speech, or before a championship game. That helps you to be more energized, activated, and it cues us to be careful. Right? We might be anxious about walking along a cliff, for example, and be more aware of the potential danger and watch our step. Anxiety is a short-term stress reaction that is part of our human experience. If you were a hunter facing a saber-toothed tiger, your brain signals to you that you are in danger. The adrenal gland produces a cascade of hormones that results in a secretion of catecholamines, especially norepinephrine and epinephrine. Your nervous system kicks in, and you may experience symptoms such as rapid breathing, sweating palms, butterflies in your stomach, muscle tension. Our response to the perceived danger may be fight, flight, or freeze. So when you encounter that tiger, you may fight the tiger or run away or be frozen with fear. The problem now is that the perceived danger may be something like a math test, or having to read in front of class, or having to navigate a school cafeteria. The brain perceives these situations as dangerous and reacts with an activation of the central nervous system, and we may respond with fight, flight, or freeze, yet this may not be adaptive for the situation. Another example, imagine you are a child playing outside and a strange, aggressive dog comes running at you. Your brain chemistry activates before you even assess the situation, and that helps you respond quickly to stay safe. But if you switch the situation slightly, that you're outside and for a walk and a strange, calm dog walks by on a leash, and your brain responds with that same danger signal, and you jump into fight, flight, or freeze, that's really not adaptive any longer. So if we think of normative anxiety and learning disabilities, I'd like everyone to take a minute just to reflect on, if you had LDs, what kinds of things in the school system might make you feel anxious. So these are the kind of things I was considering. There's lots of things in a school setting depending on the student and on the nature of the LDs. You know, for some it might be reading or writing in front of others, or answering questions if you have slow processing speed, memory problems or language problems, socially navigating a situation with peers, you know, figuring out if someone's flirting or mocking, and if you're not sure, going into a social situation can be anxiety provoking. Having to figure out how to join a conversation can be anxiety provoking. Or even in school, having to learn a new skill and then going first in a gym class without enough times to see how it's done might activate the anxiety and result in the behaviors that you might see, which could be acting up, getting in trouble, getting kicked out of gym so you don't have to actually demonstrate. So if anxiety is normal and we all have it, and students with learning disabilities are likely to experience an extra level of distress in certain circumstances, how do we know when this is a problem, especially a problem for a student in your school? How do you know when it's a problem for which mental health treatment will help? The short answer is three things. First, when it seriously interferes with the student's abilities to do the tasks of everyday life. So that might be restricting their ability to go to school, or hang out with friends at the mall, or interfering with their concentration. They can't think about schoolwork, they can't sleep. Second, when it is persistent. It's not just a period of time when a big change is happening. Like you might have a student who doesn't sleep well and is distracted in grade 8 when they're starting to worry about high school. But if it lasts at least 6 months, then that's a different story. And third, when the intensity of the student's responses are out of proportion to the perceived threat. So if there's an intense reaction going to a new place or doing something within the school that's fairly routine, or like my example of the dog walking. And we know that anxiety disorders are common, 10%, one stat, and that most anxiety disorders start in childhood. And we're talking about anxiety as a red zone. I'll talk about, so again, if it's persistent, severe, and impairs functioning. And I'll talk more about at the end about what to do. But the short story to keep in mind as we talk about this is if you have any suspicions at all that a student that you are working with is in the red zone, then it's time to get a professional assessment and diagnosis if warranted. Okay, so now we're going to have an opportunity to use some polls, and we'll go through a couple of scenarios, and when we're done, I'm going to have Cindy's help to launch a poll. But I'll explain the scenario first. In this first one, a 4-year-old girl in junior kindergarten cries and clings to her mom's leg when she gets dropped off at school every morning. However, within 5 minutes after the parent leaves, the child regroups and she's fine. So my question to you, the audience, is this a red zone concern? Do we need a mental health professional assessment? Or do you think this is maybe yellow zone, green zone, you can navigate? So Cindy, if you could launch the poll, then I'd like everyone to identify, like pick a yes or no. Thank you.
Okay, thank you, Marjorie. We have the poll launched. Should we be concerned? Select one of the following, yes or no. And we'll give the participants just a few seconds. We're at 74%. Okay, we'll close the poll in about 5 seconds. Okay, so that was interesting, Marjorie. 12% of the webinar participants indicated yes, 88% indicated no.
Great, thank you so much. So in this case, certainly for those of you who said yes, we need more information because it's possible that this is a red zone concern. I didn't give you enough information. But based on the information I gave, I think this is probably a yellow zone problem that reflects normative adjustment. The school, or I would take that as a first guess. The school experience is new to the child, the student who's learning to manage her anxiety around separations. Now, if the student continued to cry for hours and hours, or if the daily crying persisted all the way from September to June, or even past, well past Christmas, then that's when we would start to ask what else might be going on. Let's try a different scenario. Scenario number 2, a 12-year-old boy in grade 7 with LDs is driving his teacher crazy because he always asks questions. When is the next test? Who will be the substitute teacher when you're away next week? Where are we sitting at the assembly? Nonstop. And this boy is disruptive during class tests. He fidgets, he asks to get a glass of water, he acts up whenever there are class presentations, and he's generally just a pain. So again, I'm going to pass it over to Cindy for you to decide, would you be concerned, is this a red zone? Is it a yellow zone? What do you think? Thanks.
Okay, thank you, Marjorie. So the poll is open. Okay, I think we're having a little bit of, oh, no, there we go, it's popped up. So scenario 2, quick poll, should we be concerned? If the webinar participants could please select yes or no, we'll allow about 20 seconds. Okay, so Marjorie, we've closed the poll. 92% indicated yes, 8% indicated no.
Okay, well, in this case, I would side with the majority here. I would at least want to know more. Back to our criteria, is it causing a functional impairment? Yes, it's causing problems to the student. It's interfering with his learning, but it's also causing difficulty and disruption to the class, and that's significant. So we'd want to figure out what's going on. This certainly could be anxiety, as we'll talk about what those symptoms are in a minute. Okay, so our last poll, we're going up the age and grade spectrum here. So now we have a 14-year-old in grade 9 who has language-based LDs. She's very quiet and shy. She has been in the grade 9, the new school system, for several months, but still hasn't spoken to anyone. And parents say that she doesn't like to speak to anyone outside of the family. The student's in high school, and she had some acquaintances in her elementary school, but she really hasn't connected with any youth in the high school. So again, question to you, over and over to Cindy, would you be concerned? Is this a possible red zone? Do we need more assessment? Yes or no?
Okay, thank you, Marjorie. The poll is now open, so we will allow about 30 seconds for each participant to respond. Okay, so we've closed the poll now, Marjorie. 95% indicated yes, 5% indicated no.
Excellent. Thanks to everybody. So again, I would side with the majority here. I would be concerned. It seems to be functionally impairing. Now, the fact that it may have been a long history, I'd want to talk to the elementary school and just see what helped the student, what made it worse. But it would be a red flag, meaning we want to make sure that we're referring on, or that other professionals are having a look, school support team and so on. And I would wonder whether it's an anxiety problem like selective mutism, for example. Okay, so when we say anxiety disorder, what are some signs and symptoms generally in children and youth? The challenge with these signs and symptoms are that they overlap with many other things, including LDs, ADHD, depression, so it gets a little complicated. For example, extreme agitation, somatic symptoms like stomach aches, headaches on a regular basis, sleep difficulties, excessive worrying about an event, days, weeks, months before it's scheduled, being overly responsible or perfectionistic, constantly asking what if or how do you know, trouble concentrating. So as you see, lots of those things certainly could overlap with a lot of other things. And in school, what could those behaviors look like? It might look like inattention or fidgeting, frequently going to the bathroom, daydreaming, looking out the window, always asking questions, not getting things done, handing in seat work or essays, procrastination or not getting started, not answering at all, shrugging, or talking back. So again, if I just pull out those behaviors, think about the iceberg, that looks a lot like a lot of other behaviors. So how do we figure that out? Well, again, to be an anxiety disorder, problems need to be persistent, severe, and have a functional impact on the family, school, or community. And we always need to take into account the child's age and developmental stage. You know, a 5-year-old who's afraid of the dark and can't sleep without a nightlight is not so unusual. It's less common to have an early adolescent who can't sleep on their own, or who can't sleep without all the lights on and it's keeping everyone in the family awake. So again, you're going to refer on, but just to give you a sense of the types of anxiety disorders and what the categories can be, we know with the Diagnostic and Statistical Manual number 5, that's the new version, our system of classifying diagnoses. Anxiety disorders are common, affecting 6 to 10% of children and youth. And in the DSM-5, anxiety disorders are organized a little differently into 3 categories. Anxiety disorders, including this list here, generalized separation anxiety, social anxiety, panic, and specific phobia. And obsessive compulsive disorders are recognized as still within this family of anxiety disorders, but they have their own common features. And then now trauma, including post-traumatic stress disorder, is its own subcategory. And I wanted to take just a couple of these diagnoses to look at them in more detail, because these are the ones that you're often going to see in the school system with the students that you might have. We'll start with generalized anxiety disorder. Students with GAD, generalized anxiety disorder, are the general worriers. Generally, again, they have excessive, unrealistic worries that persist, that are distracting, and that interfere with everyday life. So an example, these students might hear about what's happening in Syria, for example, or hear about a bombing on the subway in London, or about the Zika virus, and are really worried about their safety here in Ontario. So disproportionate to the threat. Or they may have fears about something bad happening to a family member, not sleeping because of worry that someone will break in or they will be kidnapped, or those kind of worries. And the nature of the worries varies across individuals, but the concept here is that the worry is generalized, it's vague, it's often hard to contain, and it's often hard for the student to explain. So let's go back to our case example of Trevor. Again, you don't have a lot of information about him, but he could have generalized anxiety disorder. He gets activated by generalized worries and goes into fight mode, back to the fight, flight, or freeze. So Trevor may We see him ask questions persistently about what's going to happen and how are things going to work. You know, if he also asks these kind of questions about bad things happening, that would be common. Being distracted, inattentive, fidgety, uncomfortable in his skin, he's activated. And argumentative, it can be depression, it can be just a personality thing, but it also can be that fight reaction of an anxiety. If Trevor was your student, what would you do with a student like Trevor? Well, first and foremost, we always want to ensure his LDs are well accommodated. So let's look at what he needs for his reading and writing. I may be noticing some of his behaviors in class and want to start raising concerns about his well-being with a parent if that's available. I may ask the school support team. I know that for students that I think might be anxious, for all predictable routines are helpful. I might want to validate his experience, help to contain the worry, and give him moments to breathe, stretch, or move. And at the end, I'm going to go through some more of these in detail, but this just gives you an idea of how that would fit. So let's take another type of common anxiety disorder is separation anxiety disorder, particularly with younger kids. It's more common in females, and it reflects distress when separated, or when anticipating a separation from a caregiver. It can be functionally impairing. For example, a parent may be late to work every day because he can't get the child to school. Or an older youth with separation anxiety may not be able to be on her own. That may interfere with sleepovers with friends, or going to a sleepaway camp, or babysitting. And the last one I want to talk about as an example is social anxiety disorder. It's a common and complicated problem for students with LDs. According to DSM-5 criteria, social anxiety is a marked, intense fear of social situations. And for children, the social anxiety has to pertain to peers. It's not just a fear of strange adults. Typically, the student may have significant worries about what others will think, or may worry about feeling humiliated or rejected. And most students, most adults with social anxiety disorder had an onset of the symptoms before they were teenagers, before 15 years old. So it mostly starts in childhood. The complication is that for students with LDs who have social anxiety and often social competence, it gets a little complicated to figure this out. So students with LDs may misperceive social cues or misunderstand intentions, and they have the outcomes that social interactions don't always go so well. So it would be a normative reaction to feel a little anxious about a social situation, or to feel they're not very popular, or the student may feel like they're an outsider, all related to the LD. And you might see that activation of anxiety in a social situation. It can be tricky to figure out if there is an additional social anxiety disorder, and sort of looking at the severity. That's where an assessment is important. Plus, to treat the disorder, it's really important to take into account both the social competence and skills and the anxiety, and put them together in the intervention. The social skills alone, without attending to the social anxiety, may not be so successful, and vice versa. So let's take our case scenario of Tina. She's the 10-year-old who's very quiet. She goes to the bathroom, misses school because of somatic complaints, seems inattentive, and is particularly avoidant of crowds, such as a school assembly. So Tina could have a social anxiety. She could have a separation anxiety. We would want to investigate further. There seems to be something about the interaction with people that activates Tina's anxiety, or could be. So if Tina was your student, again, always ensuring the LDs are well accommodated and checking in with the parent and caregiver about what they're seeing at home. But this would be the kind of child where you might be mindful of the size of group if you're doing group work, and pair her with an empathic student in a group of 2 and not a group of 6. Or you might minimize the focus on oral presentations to the class and maybe give some options. So instead of standing up and doing a book report, Maybe there's an opportunity for her to do a drawing and have a mural instead of standing up and talking. And if you have school assemblies maybe, and Tina's in your class, maybe as a whole group, you start to plan for, when you go to assemblies, where is the best place for her to sit, or giving some planning prep notice that they're happening, things like that. Okay, so let's, in our last few minutes, let's figure out what you can do to help. What can we all do to help the student with LDs and anxiety in school? We want to first of all promote good mental health. The universal what's good for all. Things that are good for students with anxiety often are good for other students too. Having predictable classroom routines for an anxious student, knowing what's coming helps them to anticipate, to regulate their anxiety. Again, announcing changes in advance. For some students, announcing it too far in advance just creates an opportunity for them to worry and worry and worry. So there's sometimes the right optimal zone depending on the child, but some kind of notice helps. Creating opportunities for mastery and success. Finding creativity where the students can shine. Where possible, teaching skills such as time management, organization, study strategies may be really helpful, and opportunities for stress management, mindfulness, self-regulation. Those are all general and good mental health strategies. Specific for anxiety, what do I do? The first step really is identification. Am I concerned? Do I think there's something going on with this kid that's getting in the way of their learning? Are others concerned? So that would be checking in with the parent or guardian, talking to other school staff that might have the student in their class, or that had the student in their class last year, getting a sense. And asking yourself, is this behavior typical for the age? Or is it a typical thing for this child or youth, or is there a change? And then, am I seeing any of those red zone signs and symptoms? So as always, diagnosis is a controlled act. Educators and parents don't diagnose, but educators have a very important role as the first eyes on the child to raise some concerns. Maybe everything is fine and nothing needs to go further. But if you have concerns, then getting a child assessed, always a challenge, I think, in the school system, referring to the school support team or the equivalent, or asking for a school meeting, and then encouraging the parent or guardian to seek a referral to a mental health professional. That might include the family physician, it might include the professionals within the school system, it might include a children's mental health agency. More and more, there are mental health walk-in clinics that are really effective across the province, or a private practitioner. Most importantly, it's always better when we communicate and work together to support students, so that no one, including the student, feels on their own and unsupported. Whether or not the problems reflect serious mental health or milder levels of distress, there are often considerations and changes you can implement in the school environment that might be helpful. If we look first at strategies for the environment, knowing the individual student, you may be deliberate, or you may have an opportunity to be deliberate in your seating plan. For example, you may seat the child in the classroom near the front, where it may be quieter and less disruptive. Or you may have a child who's got some worries about bad things happening, and being near a window is really stressful for that student. So you would deliberately seat them away from the window. If you have a student, for example, who's overwhelmed by sudden changes or by crowds, then planning in advance. I've mentioned assemblies as an example. Concretely, sitting at the end of a row or arriving early or late all depends on what makes sense for that student. And it may be helpful to set up a system where the student can signal to you when he or she is feeling overwhelmed and needs to take a short break to calm and center. That might mean finding a space in a school, a library, or a resource center where the student can go instead of always going to the bathroom. As an educator, using empathy is often a great place to start. It starts with noticing a student who may be struggling and in a tactful manner, finding an opportunity to pull the student aside and listen to the concerns. You may not have an opportunity, so this is just, as an option. The idea really is to reflect the feeling. For example, you might have a student who's asking questions, and you have a chance to independently pull them aside and say, I notice you're asking a lot of questions about the upcoming field trip. Are you a little worried about how it'll go? It gives you an opportunity to validate the feeling, understanding and not judging why the student might feel that way. Lots of people feel tense when they have pop quizzes, or you're worried about the upcoming field trip. I know, are you? And you seem a little worried about getting stung by a bee on the trip or getting stung by a mosquito. And maybe this is the child who's worried about Zika. So instead of saying to the student, that's ridiculous to be worried about Zika virus in the middle of April. It won't happen on the field trip. But instead you can say, I understand you're worried about getting sick. And then you can add in questions. But, that we're going to a place where there's no cases of Zika, or we're going to a place where we'll be inside, or, so you can give some new information. And lastly, supporting the student's strengths, not giving false reassurances, but genuine acknowledgement of effort. If they're worried about a test, you've worked hard, you know this, you're ready for the test. You don't promise they'll pass the test, because you don't know that, but you can genuinely validate the strengths. As caring adults working with these students, we need to try to be patient. That can be hard. Staying calm, answering questions where appropriate, recognizing that the behavior may serve a purpose for that student. And maybe we can redirect. You answer questions, and if it's going on and disrupting other students, then you might say, come and see me at recess and I can answer your questions, or write them down and I will get them, and so on. Self-regulation skills are important for this group of students. It helps for us to model as adults how we stay calm, use positive self-talk, mindfulness, teaching breathing, that then students can see that we can feel anxious. It's a normative thing, and we can manage that anxiety. And some considerations for teaching is that it's important to keep in mind it's less effective to implement a teachable moment when a student is fully dysregulated in a panic or an agitation. So finding a time to debrief or problem solve when the student is calm, or when you are calm, is really helpful. And another tip is to avoid or resist asking too many why questions. Again, the student may not know why, or may not be able to articulate why they feel overwhelmed or why they're anxious. And for students in the red zone with significant anxiety, treatment is really effective. There are a range of interventions for anxiety disorders. Cognitive behavior therapy in particular is highly effective for anxiety. But that's not the only. There are many other approaches. Medication can be very effective, environmental accommodations and support. The key thing for the student with learning disabilities and mental health, so LDMH, is to think of the frame that therapy is learning new ways of coping, thinking about things, managing emotions, communicating. And if therapy is learning, therefore, therapy needs to be adapted and tailored for the LD student's style of learning, and how to take that into account. For example, having thought records that maybe don't involve so much reading and writing, or that we have come at things, if language is a problem, in a more creative way. And fundamentally, though, we can all help. We can support student success and mastery. We want to find ways for them to find a passion, to be strength-based, to show, if it's hard to show what they know, then how do we find a way for them to feel like they're good at something? Developing self-advocacy skills is a process that takes time, and we need to teach self-advocacy skills and be receptive to efforts at self-advocacy. That looks different as youth and students get older, but finding a way to really set students up for that will also assist in the anxiety. So I have, at the end of the slides that you'll receive when the slides get mailed to you, there are a number of resources and contact information and so on for you. Some of the resources, especially to highlight mental health assist, the School Mental Health Assist has some excellent information about anxiety, as does Supporting Minds. And Children's Mental Health Ontario has a list of children's mental health agencies that might be in your community. So I will stop there and pass it over to the LD at School group for questions.
That's wonderful. Thank you so much, Dr. Phillips, for providing our participants with an opportunity to deepen their understanding of recognizing and supporting anxiety in students with LDs. So on to the question and answer. If anyone has questions, please type your question into the chat box on your dashboard, and I will read the question to Dr. Phillips. Okay, first question, Dr. Phillips. In your experience, do boys and girls present differently with symptoms of anxiety?
Yeah, excellent question. So specifically, the research would suggest with for students with LDs and anxiety that the rates of anxiety in the students is the same. So there's no gender difference. However, when you look at the presentation, it would appear that girls tend to be more into that flight, so anxious or freeze, so they may be quieter, they may go under the radar, and would appear that boys might be more likely to go into fight, be more argumentative, but it's not, definitely that's not a perfect science. And so in fact, there are higher rates of identification of anxiety in girls, and what we don't know is just whether that's because we can pick it out easily, that they're the ones that look anxious, they're quiet, they acknowledge worries, and boys might be a bit sometimes harder to tell.
Okay, thank you. Next question. What would the biggest difference be for dealing with anxiety for children with learning disabilities versus students or children without learning disabilities?
Excellent question. I think the bigger difference for the LD plus anxiety group is just recognizing the overlap of the symptoms and sort of figuring things out. It's very easy to look, for example, a symptom might be looking distracted. And so is that, and the student's having trouble concentrating. So is it because they're distracted by their worries, they can't let it go, and they're thinking about all the, they're worrying about what people will think of them, or they're worrying that they didn't study hard enough for their test and they're going to fail and their parents are going to be mad at them? Or is it that they're not paying attention, they're distracted because they have slower processing speed and the information's come at them too quickly? And then we have the kids that have both, where it's, their LD can get in the way of managing the anxiety. So if I have difficulty with processing speed and working memory, and I've got some go-to strategies to self-talk, remind myself to, tell myself it's going to be fine, to do some deep breaths, but maybe I can't remember what I was going to tell myself, and I'm overwhelmed, I'm not paying attention to what the teacher's saying at the same time with my LD. So I think it just complicates. Our view is that the anxiety is the anxiety, and then the LD can complicate the management and identification.
Okay, thank you. Next question. Have you worked with students within the Aboriginal population, and do you see differences when it comes to anxiety, LDs, and mental health?
That's an excellent question, and I don't. The answer is I don't know. I'm not familiar enough with the Indigenous literature. I know the LD and MH literature is very slim. We just don't, this is a new field that we're just not there on. So I have not seen any literature about anxiety in students who are First Nations or Aboriginal or Indigenous and LD. And I just don't, yeah, I wouldn't say I'm an expert in the area.
Okay, thank you. This sounds like a future research field.
Absolutely.
Next question. How do you manage, and obviously from a teacher perspective, when a student is in the red zone, fight, flight mode, and there are 20 other students to manage?
Yes, absolutely. It is so difficult. I guess partly a recognition that you're already doing it. So if you think of the student who has burst into tears and runs out of your classroom, or who starts talking back to you as an educator, I mean, part of this is just recognizing, oh, where did that come from? You know, is that the student reacting to, or, you know, are they flooded because they're anxious about something, you know, an unexpected test, or, you know, so the first step is to start to be curious about a kid and start to notice patterns. Like every time we're in French class, this kid starts to talk back and pick a fight, or is non-compliant or refuses to write, or every time I pull out the test. Once a child is fully activated, their sympathetic nervous system is activated and they're in full-on panic mode, then that's not the best time to intervene. Ideally, it's another time, and you can cue the student to take a deep breath, or to go have a break, you know, that you've worked it out, so that when they get overwhelmed, they can leave for 5 minutes, calm themselves down in a quiet place, do a body scan, whatever their strategies are. But I think my last point would be, if a student's really in the fight mode, I think it's really easy to argue back and get into these power struggles, you know, because the student can be saying, that wasn't fair, or this is ridiculous, or and I think just being able to recognize and say, staying calm ourselves, staying calm yourself, and saying to the student, it sounds like you're really distressed about this, I need you to take 5 minutes, we'll come back, or, you know, something. It is difficult.
Well, thank you, Marjorie. I know as a teacher myself, it can be very, very challenging to try to deal with what appears to be spiraling behavior when you've got other students in the class. And I really liked your suggestion of being aware and looking for the signs that things might be starting to ramp up, and to be able to be more preemptive and proactive. Okay, next question. Is cognitive behavioral therapy a successful intervention for children with language-based learning disabilities?
That is an excellent question. I love that one. The answer is yes, absolutely, if it's tailored. So one of the things we have I think good fortune at Integra, because we provide mental health therapy exclusively to this population, we've really developed some good techniques. What we find most helpful is to use what's called a core elements approach to an evidence-based therapy. So that simply means that based on what the evidence says is most effective, we pull it out. So for example, in cognitive behavior therapy, something like cognitive restructuring, or thinking about things differently, or exposures, you know, facing your fears, regulation skills, all those are core psychoeducation, those are core elements. Then we have to take the core elements and we get really creative. So a core element might be a cognitive restructuring. So we know we have to find those hot thoughts, those cool thoughts, and challenge them. How do you do it if you can't access your language? So we find other creative ways to get at what's driving a student. And so an example at Integra, we have Integra Mindfulness Martial Arts that incorporates cognitive behavior therapy principles with mindfulness and martial arts. And we're finding it's very effective for students with low language. They learn by doing, but it's still taking the principles of CBT.
Okay, thank you, Marjorie. And I'm glad you mentioned mindfulness martial arts. This gives us an opportunity to promote a video that we have on the LD at School website. Next question. As someone who was diagnosed with a learning disability, only to find out about it years after my education, what are your recommendations about sharing or disclosing this type of information to students with learning disabilities?
Well, I think it can be a sensitive issue, especially for parents who may feel very strongly that they worry about stigma or a student being labeled. And I think what we've really come to at Integra is that it's really, really important for students to understand what's going on with them and to be able to have the words to explain to others. And so our long-term hope is really to reduce the stigma around having a learning disability. We hear from the youth all the time that they hate the word disability. They're not disabled, they can learn. And yet for others who have learning disabilities, it's that it's a serious thing. It's not just that they don't like to do math, it's that they're significantly have significant impairments and they need to have accommodations to level the playing field. So my view is that finding the right words and giving feedback to students when at the time of their assessment and then ongoing, to have an opportunity to sit down and really understand how do they learn, what's hard and why, what works for them and why, and how, so that's the first step for them to be able to self-advocate. But it's a multi-step, multi-approach. One of the other things we do at Integra is have workshops called Walk a Mile in My Shoes sort of simulation to activate empathy. And we'll do that with other students as well, so that students aren't singled out, but that there's an increased awareness for everybody of what it's like to struggle if you have these particular impairments.
Thank you, Marjorie. Simulation activities can be especially powerful, not only for students, but for the educators too. Next question. What could be some steps that an educator could take to encourage a reluctant or avoidant teen, young adult to speak with a professional?
Right. So back to kind of that experiential avoidance. I think the first step is understanding that it is hard. I mean, sometimes as adults we get frustrated because it's hard, the waiting lists are long for mental health services, and you finally get a student in to see somebody and then they don't want to go, or parents can feel that way too. So understanding it for the student, it may seem a weird thing to talk to someone about your feelings. If you feel bad, it may make you feel worse, is the idea. So I think to me, the most important thing is a relationship with the adult and the student, so that the student really has a trust that this is someone who cares about them and is not trying to make them just feel worse, but actually wants things to go better for them, and that they need a place where they really feel comfortable to understand what's going on. And sometimes giving permission to the students that it's okay if you don't click with the first person you talk to, that sometimes we have to find the right, you got to give it a chance. So often I'll talk to youth about trying 3 times, to really give this person a chance, get to know them a bit before you give up, but also to recognize that just because that person wasn't the right fit for you doesn't mean you'll never benefit from therapy. There's same with lots of things. And then lastly, ideally finding a therapist or an individual that kind of gets the LD part, so that the student really, that we can put the LD and the MH together.
Okay, thank you again, Marjorie. The next question is about the referral process, wondering how would either a teacher or a parent refer a child to Integra?
Oh, to Integra? Well, to Integra specifically, we have a catchment limit of Toronto. So they have to be in Toronto, and they would the website information is there. They call, the student has to have a diagnosed LD. We can take referrals from teachers or from parents. We would get parent consent if it comes from a teacher. It can start anywhere. But we are only limited in Toronto. So we've been starting to share our programs to other parts of the province, and we're always keen. We have a wonderful partnership with the Trillium Lakeland District School Board, where we've been, Trillium Lakelands has been implementing Integra Mindfulness Martial Arts and now Integra Young Warriors in elementary schools and in one of their high schools. So that's our long-term hope, is to share what we know. But I think broader than that, if you're in a community, then activating, there are children's mental health services, and we're really always activating to try to get more services. I think going to the CMHO website to see which agency is closest to you as an educator, or looking at what the partnership is. I'm guessing that schools that have school mental health assists, or the mental health lead in their school, would be connected, starting with the school social worker or a school psychologist. Might also know good referral sources. But for families, often the family doctor is a first step, or more and more the walk-in clinics. There are mental health walk-in clinics, I think, in many communities as a first step.
Thank you, Marjorie. Next question, how do we support students and families if the family doesn't believe the student has anxiety?
Right. So that, yeah, because sometimes, again, back to we don't always know what the history is for a family, and you can have it's the same thing, especially with this LD plus anxiety group we're talking about. For some parents who may themselves have had learning difficulties that were never diagnosed as children, and for them, school may have associations of being kind of an overwhelming, intimidating, not a pleasant place. Or maybe they were in trouble all the time, or maybe they just were sick all the time and didn't go. And then we also know anxiety runs in families. So you may also have a parent who has anxiety themselves, and so hearing about their own child, that you're concerned about their child, might activate a lot of things in that parent. So first of all, have, as best you can, have empathy for that parent who you might think is just being not doing the best for their child. They may be coming from a place themselves, and we just don't know what that is. And then next, I think so that's where pulling in the other teams and finding all the different avenues that we have to give feedback to families. For the student, him or herself in class, there are lots of strategies that, I alluded to, and then others that are good for all. It's not singling out a student, it's just good teaching practices, like being predictable. And so that you can help, even if you aren't sure a student has anxiety or the parent doesn't agree with you, you can still do some things that make school more comfortable for the student in front of you. And then lastly, I think recognizing that there are differences across scenarios. That's why the very first part is to find out, where else is this happening? Because it could be that the student is very anxious at school only, but at home they're really not. So it's not a question of the teacher's right and the parent's wrong. They're both right. It's that the student presents differently in different contexts.
Okay. Our next question, what are some considerations for educators or school support services in a situation where a student consistently may be in the red zone and avoids a particular class, such as math?
Right. Well, I think the first, and again, every school system has their own, I respect the system. So you start with whatever the system is in your board and your school around school support teams or the equivalent. Because I think having a meeting with the relevant players in a school system to know whether is it that they only ever avoid math class, or are they is it always just that it's first period, or is it that there's something about that particular student-teacher dynamic, or is it, were they also like that in math last year? So again, trying to figure this out, what might be going on. Is it about the nature of the task demand, or is it something else? And then also problem solving with the parent and the youth, depending on the age, to try to figure out what makes it hard to get to this math class and how can we get there. For some students, it could be something like math that is cumulative, or a more social science, and the student gets behind. They've missed, they haven't been able to concentrate, they don't have the building blocks, and as the term goes on, they get farther and farther behind and feel horrible. And so the easiest, back to that experiential avoidance, they just put their head in the sand, play video games, and just can't get to class. So in that case, then having a team meeting with all the players to really problem solve, okay, how do we get the student with the curriculum they need to have for this term. What supports? What do we, what extensions do we give? What extra tutoring does the person need? What, and problem solve.
Okay, so just building on that last question and answer, in your experience, do students who have learning disabilities experience more anxiety in a math class as opposed to another type of class?
I would say that it completely depends on the nature of the LDs. So we have some students, if their LDs really impact math. So for example, if they have lots of working memory difficulties, or they, whatever the nature, or writing, graphomotor, they have trouble, they put their numbers in the wrong, they disorganize and their space is off, and so then they get their calculations wrong, or they have language-based LDs, and then as word problems get more complicated. So looking at the nature of the LDs and their individual education plan, students with LDs and math kind of problems and may feel more anxious in a math class. But you can also have students who are just generally, math may be a pretty good subject, but they have a significant anxiety disorder, and it could be the social aspect of going to school. It could be being just worrying about things happening, and so they may look quite anxious in a math class.
Okay. That's all the time we have for today, so we're going to end our question and answer session at this time. Should you have any further questions, please either email us at info@ld@school.ca or send us a tweet to @ld@school, and we will ensure your questions get answered. Please mark your calendars for the next LD at School webinar on Thursday, May 25th. Janessa Dwart and Chris Sands, both educators with the Toronto District School Board, will be presenting on strategies to support the success of students with LDs on exams and standardized tests. This is a very timely webinar. Directly after today's webinar, you will receive an electronic link to register. Before we wrap up, we would like to make you aware of LD at Home, an exciting new online resource for parents and families of individuals with LDs. Produced by LDAO, with support from the Ontario Trillium Foundation, LD at Home will provide education, knowledge, and resources, along with a place for families to connect with the LDA network across Ontario. As educators, this is a great resource to share with parents. And finally, please mark your calendar and save the date to join us at LD at School's 4th Annual Educators Institute, which will be held on August 22nd and 23rd in Mississauga. The last 3 years have been a sellout, and public registration opens on May 6. Check out the LD at School website for information on the program, registration, and hotel accommodation. And on behalf of the LD at School team, I would once again like to thank Dr. Phillips for her presentation, and thank you to all of our participants for joining us. Please remember that we will be sending out presentation slides as well as a short survey following today's webinar. The feedback we received through the survey provides us with important information for producing future webinars. And as a reminder, we will be sending out a link to this recorded webinar in approximately 3 weeks. Thank you again for participating in our second LD at School webinar, and enjoy the rest of your day.